Good morning or afternoon to those of you at the Bangkok Symposium. Very disappointed that I can't attend this year, having been there every year for many, many years. It's a great honour for me to give this talk in honour of Professor David Cooper as a memorial lecture and an update on COVID-19 vaccines. So all of you watching this today would know well that David would be in Bangkok every January. He loved that meeting and he had a very deep and long relationship with many investigators in Thailand. Preparing for this talk on COVID-19, I of course was thinking and have thought at many times throughout 2020, what would David do if he was here managing and playing a role in the response to COVID-19? And many times I think of what would have been his vision, and how these clarity of seeing the most important issues and how to respond to them came so easily to David. But what I do know is that I think David would be incredibly proud of what has been achieved, particularly in the Asia-Pacific region and also in Australia and Thailand. This shows the devastating number of people infected with COVID-19 from January the 6th, with huge numbers continuing in Europe and the US, but yet a tiny proportion of cases being diagnosed in Southeast Asia and the Pacific and Africa. Thailand and Australia have both done incredibly well, although I understand Thailand is now battling an outbreak, but I'm sure they'll get on top of that with the public health measures that they've used before to effectively control transmission. Australia has also had a very good response. Our outbreak in COVID has been characterised by 2 waves of infection. The first in March was widely distributed across the country, as you can see by different colours related to the different states across Australia. Most of this was imported infection from around the world with some limited local community transmission. We then, however, had a second wave, which was predominantly in Victoria, where I live. You can see here coloured in blue, which was quite different, reached a peak of 750 cases a day, a total of 20,000 cases diagnosed, and significant community transmission, including infection of healthcare workers, infection of aged care residents, and a significant number of deaths of the elderly. There was a spectacular response from the government and from the community with complete control. And in fact, we had 60 days of 0 coronavirus infections until a small outbreak. And this is the numbers of cases around the country over the last 14 days, again, colour-coded by the state in which they occurred. And you can see if you just look at community transmission over the last 14 days, these are tiny, tiny numbers in the range of between 0 and 10 cases. And I think it's important and valuable to reflect on some of the lessons of our response. First of all, very clearly, non-pharmaceutical interventions work. They do come at great cost, but they definitely work. Australia's response was characterised by being rapid and early. Public health was prioritised. We had the luxury of being able to close international borders, which many places are unable to do. We've continually had high rates of testing since mid-January, low positivity rates. Currently, it's around 1 in 10,000. And thankfully, our policy has been continually informed by science. A lesson that we learned in our response to HIV, and I know it's a lesson that Thailand knows well as well. Victoria's strategy had an added extra dimension because there was so much community transmission. This was managed with a long and strict lockdown, mandated universal masks, which were previously never worn at all in a country like Australia. We went to the extent of overnight curfews. The government did some very good social interventions, including social support such as paid COVID leave. So even if you were a casual worker or an overseas worker, if you had to take time off from COVID, you received payment. And I think the real secret, and this came with great debate and tension, was opening up slowly. We had 0 cases for more than 28 days before shops, bars, restaurants reopened. And I think this was the reason why we were able to maintain such low levels of transmission subsequently. But I'm not going to talk about non-pharmaceutical interventions today, other than to say they work when they can be implemented, but talk to you about the rapid and very impressive field of COVID-19 vaccines. I'll start with the review of antibodies and how they protect from SARS-CoV-2, talk about the different COVID-19 vaccine platforms. I'll spend most time talking about the mRNA and live vector COVID-19 vaccines, as these are all now being rolled out and used and authorised, with a particular focus on phase 3 trial results, and finally end on some emerging controversies and future challenges. So we now know that antibodies from infection really do protect from reinfection. This very nice prospective study from the New England Journal of Medicine looked at 12,500 healthcare workers in the UK. They measured anti-spike IgG, not neutralising antibodies, total antibodies at baseline, and then followed these participants for 6 months to determine the number of people that became PCR positive over that period. There were 223 PCR positive cases in those who were antibody negative at baseline versus 2 PCR positive cases in those who were antibody positive at baseline. This led to an adjusted incidence ratio of acquiring COVID of 0.11, or a reduction of 90% in your risk of acquiring COVID if you have had COVID before. This is promising. It tells us that reinfection is rare and that you do have protection at least for the first 6 months, and it's directly linked to the presence of anti-spike IgG antibodies. The level of antibodies that protect against infection still remain unknown. But this very nice, elegant work done by Dan Baruch carefully looked at the role of antibodies in a rhesus macaque model. In this study, rhesus macaques were infected with SARS-CoV-2 and convalescent plasma was collected and purified. That plasma was then infused in uninfected rhesus macaques, and then the rhesus macaques were challenged with virus. And then virus was measured in both the bronchoalveolar lavage, or lower respiratory tract, and in the nasal swabs. And you can see here that in the monkeys that received a high concentration of antibodies, 250 milligrams per kilogram, none of the monkeys were infected, as compared to 2.5 milligrams per kilogram, where 3 out of 3 monkeys were infected. So this is a very direct evidence that antibodies from convalescent plasma protect against infection, and the level of antibody is critical in determining the level of infection. Dan's group tried to look at this more closely to identify the threshold level above which the animals were no longer protected. And these data are shown as animals who were protected in red or not protected in grey, with levels of antibodies measured in blood, and protection was defined by either virus in bronchoalveolar lavage, the lower respiratory tract, or the nasal swab. And you can see here that there is protection at a certain level of both neutralizing virus and total antibodies, which is similar for protection against infection in both the lower and upper respiratory tract. In this study, the investigators also looked at the role of CD8 T cells in protection. They play some role, but only partially protected animals from infection. So antibodies are absolutely key. And what COVID-19 vaccine platforms have been evaluated? Well, first of all, most of the vaccines to date target the spike protein, or more specifically, the RBD, or receptor binding domain. What do I mean by the spike protein? Well, on the surface of coronavirus, you have envelope proteins embedded in the lipid bilayer, but protruding from the surface are these spike proteins, which are unique to coronavirus. The spike protein forms a trimer, which is shown nicely here, and it has 2 subunits, S1 and S2. And then a more detailed analysis of the spike protein shows you the different components, the most important being this very tip, or the RBD, or receptor binding domain protein. And if you think of the spike protein as the arm coming out of the coronavirus, the RBD is like the fingertips. Now, this spike protein has got some major challenges. First of all, it is somewhat variable, and we're seeing this with reports of these new mutant strains coming out of the UK and South Africa. Not as variable as HIV and influenza, but still certainly variable. And the stability of this spike protein is absolutely key in generating adequate immune response. And what's optimal is to have this, if you don't stabilize the spike protein, the 3 parts of the trimer flop around and you can't get the appropriate antibody response needed. So there's been various ways that you can stabilize the trimer in a pre-fusion conformation. And one of the most successful ways has been using 2 proline mutations that enhance the stability of the trimer. And this is called the SARS-CoV-2 S2P. It was a discovery actually made with MERS, but then rapidly been introduced to strategies for SARS-CoV-2 and has been the basis of most of the vaccines that target spike protein. Now, the vaccine platforms have ranged across traditional platforms such as protein-based vaccines, which you'd be very familiar with, or inactivated virus platforms, again, what you'd be familiar with from polio and other inactivated vaccines. But interestingly, the 2 platforms that have moved the quickest into the clinic include nucleic acid vaccines and viral vector vaccines. Nucleic acid vaccines include both DNA and RNA. They've never been licensed before. And viral vector vaccines can include replicating and not non-replicating vectors. Again, never licensed before for the treatment of a prevention of an infectious disease. And I'm going to focus on these 2 platforms as they've been the first to reach widespread authorization. So mRNA vaccines appear to be extremely potent. Here's a schematic of how the mRNA vaccines work. The RNA sits within a lipid nanoparticle. This is injected directly into a muscle cell where viral proteins are produced. There's no integration, of course, of that RNA. And those proteins are then expressed on the surface of the cell or taken up by dendritic cells and induce a robust immune response. There's different types of RNA vaccines, and in fact, there's been quite a lot of work on RNA vaccines prior to COVID-19, just none have reached phase 3 or commercialization. There are self-amplifying RNA vaccines, and there are non-replicating RNA vaccines. The non-replicating form are the ones that are now available, and they're introduced by direct injection using a lipid carrier. Prior phase 1-2 clinical trials have been done with other RNA vaccines for HIV, Zika, and influenza, but no phase 3 studies. There's quite a lot of experience on the development of RNA vaccines for cancer. But there are persistent challenges. First of all, manufacturing at scale is a challenge, and many countries don't have the capacity to manufacture RNA vaccines, including a country like Australia. They're more costly, and they also require a cold chain that's variable between -80 or -20 degrees, different to what is required for a protein vaccine. But I anticipate that over coming weeks to months, we will see progress on these particular challenges. There's a very large number of groups working on RNA vaccines. I'm going to speak to you about these 2, the Pfizer-BioNTech and Moderna vaccines that now have emergency use approval in many countries and, in fact, full approval in other countries. I note that Chulalongkorn University has also got a phase 1 study of an mRNA vaccine. The other RNA vaccines do differ from these 2, but they're still in phase 1 or 2 levels. The Pfizer vaccine has been uses the S2P protein, the spike protein with the double proline mutation to lock it into its pre-fusion conformation. And the first assessment of immunogenicity looked very promising. I show these data just to give you a feel for the level of antibody that is similar, as you can see here, in young people, old people, and in people that recover from SARS-CoV-2. You can see there is lower levels of antibody in the over 65 age group. And you can also see that antibodies really increase significantly after that second dose given on day 21. There have been many studies that have now reported immunogenicity. They've reported antibody levels of neutralizing antibody, levels of CD4 and CD8 T cells, but it's likely that the neutralizing antibody titer is one of the most important in predicting protection, as I showed you for natural infection. Now, these are the results of the phase 3 study. It was a randomized placebo-controlled study in over 37,000 individuals, and the results are simply spectacular. In red, you can see the number of COVID cases, the cumulative incidence of COVID in those that received the vaccine compared to those that received placebo in blue. And the primary endpoint after both doses for symptomatic COVID with clear evidence of infection, meaning that they were diagnosed with SARS-CoV-2, was 95%, with this confidence interval of between 90 and 97%. Secondary endpoint was severe COVID, and in this analysis after the first dose, the vaccine efficacy in preventing severe COVID was also very high, 88.9%, with a wide confidence interval. The efficacy between first and second doses was definitely measurable. The vaccine efficacy was 52%, and you can see that's here blown up because dose 1 is given at day 0, dose 2 at 21. You can see by about 10 days there's separation of the two curves indicating protection, which had an efficacy of 52%. And finally, there was a large number of different subgroups that were successfully enrolled in this study, including the elderly, people with HIV, racially diverse group, and overall the vaccine efficacy amongst subgroups was largely consistent with the overall findings. Now, the results of the Moderna vaccine have also just been published in the New England Journal of Medicine at the end of last year, and the curves almost look identical. This time the mRNA Moderna vaccine is shown in blue, placebo in grey. They did a per protocol and modified intention to treat analysis. The per protocol analysis had a vaccine efficacy of 95.2%, the confidence interval of 91.2 to 97.4, very, very impressive. The vaccine efficacy for severe COVID, this time measured at 14 days after the second dose, was 100%. The efficacy for the Moderna vaccine between the first and second doses was slightly higher than for Pfizer, and it was had a calculation of 80.2%. And finally, just as I showed earlier, the vaccine efficacy amongst subgroups was consistent with overall findings. So spectacular results from these initial large phase 3 studies. However, there are many unknowns about the vaccines that we now have. And this was really well summarised in the Moderna FDA briefing document that was last updated in November 25th of last year. And in that briefing document, the unknown benefits were highlighted. And I think these are relevant to all vaccines that are currently becoming available. We do not know the duration of protection against COVID. We do not know the effectiveness in populations at high risks of severe COVID disease, particularly people with HIV. There were HIV positive participants, but the numbers were small, in the range of hundreds amongst 30 to 40,000 participants in the larger study. We don't know the effectiveness in individuals who were previously infected with SARS-CoV-2, though they were infrequent in both studies. We don't know the effectiveness in pediatric populations. The youngest participant, at least in the Moderna study, was 17. And we don't know the vaccine effectiveness against asymptomatic infection, long-term effects of COVID-19 disease, mortality, and most importantly, transmission of SARS-CoV-2. Animal studies of the Moderna vaccine showed a reduction in lung viral load in following vaccination, but only a partial reduction in viral load in the nose, suggesting that transmission could still occur in those that are vaccinated. It's a very big issue for introducing vaccines in countries like Australia and Thailand, which have very low incidence. There's also a large number of unknown risks. The safety in certain populations, particularly pregnancy and lactating women, pediatric population, and the immunocompromised. We don't know about adverse reactions that are rare or require longer follow-up. In the Moderna study, that Bell's palsy occurred in 3 vaccinees and in 1 placebo recipient, and this needs to be watched closely. We don't know whether eventually vaccine-enhanced disease might occur with a reduction in antibody. The viral vector vaccines are also moving ahead at a rapid rate. This shows you a schematic of either replicating viral vectors that enter a cell, replicate, and then are taken up by dendritic cells and their proteins expressed, or non-replicating viral vectors that are directly taken up by dendritic cells and generate an immune response. Typical viral vectors used here include the adenoviruses and pox viruses. The adenoviruses have been most widely worked on, largely because they target mucosal inductive sites. They infect both dividing and non-dividing dendritic cells. They're thought to be safe, they don't integrate, they're physically and genetically stable. And the main adenoviruses that have been developed are adenovirus 26, adenovirus 5, which you'll remember was used for HIV vaccines in the STEP trial, which is relevant, and I'll come to back to that later, and the chimpanzee adenovirus. Again, there are multiple viral vector candidates in phase 3 studies now, and emergency use authorization of the AstraZeneca vaccine, AZD1222 or Covishield. The Gamaleya Research Institute vaccine has also received emergency use authorization in Russia and some Middle Eastern countries. You can see here that these vaccines largely need 2 doses, just like the RNA vaccine, but one recombinant novel coronavirus adenovirus type 5 vector is looking at a single dose. The rollout and assessment of the AstraZeneca vaccine has been slightly complicated and much more complicated than the RNA vaccines. This just summarises the main 4 studies that are informing the vaccine efficacy results that are now being used. There were 4 studies, COVE 1, 2, 3, and 4. 2 were performed in the UK and 1 in Brazil and 1 in South Africa. And as with all COVID studies, an overlap of phase 1 and 2 and 2 and 3 to accelerate the development of these vaccines. You'll see that this initial phase 1-2 study, a small number of participants did receive a single dose, only 88 out of a total of over 1,000 participants who received a double dose. In this second cohort, there was a mixed dose schedule administered. About a third of the participants received the first dose as a low dose and the second dose as a standard dose. And 2/3 of participants received standard dose at the first and second doses. And finally, there's a large phase 3 study with over 4,000 participants from Brazil, where just the standard dose was used and used 12 weeks apart. Low dose and standard dose don't differ a lot, just about 50% of the actual dose. And so when you're interpreting this efficacy, you've got to keep in mind these different doses that were used. This is pooled results from 3 of the COVID studies. And you can see here the COVID vaccine in red, the controls, which was either saline or meningococcal vaccine, and the primary efficacy analysis on the left of both the standard or low dose standard vaccination, and the secondary efficacy analysis for the first standard dose. The overall primary endpoint for symptomatic COVID was 70%, so clearly lower than what we've observed for the mRNA vaccines. Secondary endpoints again included severe COVID, and the efficacy was high of 100%. But in this study, they also did weekly swabs for a number of participants, and so were able to determine the efficacy against any PCR positive swab, and that was 55%. And again, subgroups performed similarly. So it's unclear why the efficacy was lower. Further analysis is happening right now. There was certainly higher efficacy if just the low dose was analysed, but that was a post hoc analysis. There are many other vaccines in advanced development. You'll see here the viral vectors and mRNA vaccines, but there's also DNA vaccines, protein-based and inactivated vaccines. Other clinical trials have announced the results of their phase 3 studies, with Gamaleya, a viral vector, having a vaccine efficacy of 91%, and Sinopharm, an inactivated COVID vaccine, having an efficacy of 79%, but those data are not currently published. We've been also working on vaccines in Australia. The vaccine that we're currently most excited about is a protein vaccine that targets the receptor binding domain, used with a novel adjuvant. And this shows you protection in a mouse model. You can see here we measured lung viral load. This work's been led by Godfrey at the Doherty Institute. Whether you administered subcutaneous or intranasally with either adjuvant, you got universal protection against infection. But what we were particularly excited about was when we looked at viral load in the nose. I remember I mentioned earlier that many of the other vaccines did not reduce viral load in the nose. And you can see here, particularly with the use of subcutaneous vaccine and this second adjuvant, that 4 out of the 5 animals had undetectable viral load in nose, which would be very promising for reducing transmission. And we've just recently received funding to start a phase 1 study of this vaccine being led by Terry Knoll, and we hope in the second quarter of 2021. Finally, there are multiple emerging controversies and future challenges as these very successful vaccines are being rolled out. The first is whether we can get away with 1 dose. This has been proposed largely from the UK, and also extending the period between vaccinations out to 12 weeks to allow for quicker rollout and increased herd immunity. This is quite controversial. The FDA have recently come out with a very firm statement that this is not acceptable. This was not tested in clinical trials, and this sort of questions need to be answered systematically. Not something that we're considering doing in Australia, given the current situation that we're facing. There are new mutant strains that all of you would have read about from the UK and South Africa. We don't know yet whether vaccine-induced protection from these strains occurs. We do know that a prior mutant strain, the D614G, that rapidly took over in North America, is indeed fully sensitive to neutralisation, and actually even maybe more sensitive than wild type. So this work needs to be done to understand the impact on neutralisation. And there's some concern whether vaccination could drive emergence of new variants, especially if inadequate antibodies are achieved, but there's no evidence of this to date. I think the strategy for rolling out vaccines is quite complex in low incidence countries where we're trying to eliminate infection or have eliminated infection, particularly if these vaccines don't protect against transmission or have reduced efficacy against transmission, and we don't yet know the answer to that. COVID vaccines in people living with HIV, there have been many people with HIV have participated in these large phase 3 studies, which is fantastic, but there's limited numbers, and we really don't know the efficacy and safety in the same extent as people without HIV. And finally, there's a very interesting theoretical, but I think real concern about using adenoviruses in people at high risk of HIV. And the concern comes from our knowledge of what happened with adenovirus 5 when it was used as an HIV vaccine. You will remember the STEP trial and a follow-up study in South Africa, where there was evidence of enhanced infection, potentially enhanced infection in people that received the vaccine, potentially related to how HIV replicates in adenovirus-specific CD4 T cells. And of course, one of our biggest challenges that faces us everywhere around the world is COVID vaccine hesitancy. This large online survey of over 18,000 adults across the world showed overall that the response to if a vaccine was available, I would get it. About 73% agreed or somewhat agreed. And you can see the wide variation in acceptance, very high in India and one of the lowest in the United States. So in summary, we have 3 SARS-CoV-2 vaccines that are licensed in preventing COVID-19 disease. This has been an extraordinary achievement, not just on the basis of vaccine efficacy, but on the basis of speed. And there will be more to come, and they're coming thick and fast. New platforms such as mRNA and viral vectors could transform our vaccine approaches for other infections such as HIV, hepatitis C, influenza. I think this will be the silver lining of COVID. Implementation at scale remains a very significant challenge, even for the most sophisticated countries. Rolling out that vaccine, given cost, storage, availability, vaccine hesitancy, let alone access to appropriate products from low-income countries. And implementation strategies will really differ in high and low incidence settings, as we're already seeing. And finally, and I think this is how I think David Cooper would be thinking about our response to COVID-19. We absolutely need to listen and heed the lessons from HIV to avoid nationalistic responses that jeopardise global access to solutions and cannot succeed against a global pandemic, and hoping that this will continue and get stronger over 2021. Thank you to many of my colleagues at the Doherty Institute, particularly Terry Nolan, Candice Ubero and Dow Godfrey, who provided slides, and the many funders that have supported our work in COVID-19. Thanks very much.